As I was saying, my name is Christopher Scalchunes. I'll be your moderator, or attempting to be your moderator, today for the future of clinical informatics. I'm excited to welcome Dr. Adi Gunlapalli, who will be presenting this enlightening discussion. There'll be time for questions at the end of the presentation, so please submit any questions you have to the presenter in the Q&A section of the CVent platform. So Dr. Adi Gunlapalli is a physician and informatician who currently serves as a Chief Public Health Informatics Officer at their Center for Surveillance, Epidemiology, and Laboratory Services in their Centers for Disease Control and Prevention, or CDC. In this role, he has been actively involved in the national response to COVID-19 with regard to data and analytics. Prior to joining the CDC in Atlanta, he was a professor of medicine at the University of Utah School of Medicine, with training and experience in both infectious diseases and clinical and laboratory immunology. And this was between 2016 and 2019. Dr. Gunlapalli has provided both outpatient and inpatient consultations for patients with primary and secondary immune deficiencies in the Intermountain West. He's been actively involved with IDF for our patient outreach and research activities, which he and I have participated in jointly many times. So thank you, Dr. Gunlapalli. While he was at the University of Utah. So please join me in welcoming Dr. Gunlapalli. So Dr. Gunlapalli, please go ahead and take it away. I'm going to mute myself.
Thank you. Thank you, Chris, and good afternoon or good morning, everyone.
I think you may be on mute.
Yeah, let me see. I did unmute myself. Is it any better now? Chris, you may have muted your speaker then, if you could check. And I'm checking again.
Dr. Gunlapalli, I'm not sure that I can hear you.
Okay. During the sound check, it had worked, and I didn't change any settings, but I'll try muting and unmuting again. Is it any better now? Can you hear me?
I think we're still having difficulties. Hold on one moment.
Okay.
Okay, apparently we're good. We can hear just fine. Please continue the presentation. I apologize.
Oh, no problem. Thank you. Well, I was saying good afternoon or good morning if anyone's on far on the West Coast or beyond. It's really a pleasure to be here, and I appreciate IDF and specifically Chris inviting me to come and share some thoughts this afternoon. So let me share my screen. Put in presentation mode, and I'm hoping you can see my screen. I'd like to maybe share some thoughts for about 25-30 minutes or so, and then would be happy to take questions and a discussion and your comments on this. So the title for today, Leveraging Big Data for the Primary Immune Deficiency Community, and as part of your IDF conference there. Just to make sure, no financial disclosures or conflicts of interest, and I'm a federal employee, so the findings and conclusions in this presentation are mine and do not necessarily represent the official position of the Centers for Disease Control and Prevention. Today, the discussion outline is fairly simple. I wanted to give you an introduction to big data, real-world healthcare data, and registry data, which I think you're all familiar with. Talk a little bit about big data and the primary immune deficiency patient, or PI, patient journey, which you are extremely familiar with, and then wrap up with some discussion and Q&A after that. So big data, as you all know, you've heard this many, many times. I think it's all over the media and news and articles everywhere. Officially, though, there is a definition or a description, and this is from a government website, the National Institute of Standards and Technology, NIST. So big data is a term used to describe the large amount of data in the networked, digitized, sensor-laden, information-driven world. So it's not just medical. Actually, medical is probably late to the game here. The big data is in many, many other spheres. It refers to data sets that are too large or complex to be dealt with by traditional data processing application software. So these data sets are not those that you can just download on your home laptop, and then work on them overnight and then be able to analyze them. They're extremely large, but you won't even be able to download them on a laptop. They consist of structured and unstructured data, and we'll talk a little bit about that later. Essentially, structured is where you have a value that goes into a box and can then go into a table, like a number or yes, no, etc., or a word that's pre-selected. Unstructured data for our purposes in clinical care will be a written note. So your provider writing a note in the electronic medical record is unstructured data. Big data are in every domain, as I mentioned. So you see it in the financial sector, airline, transportation, everywhere. Now, big data has many different qualities, but for the past several years, these are the 5 sort of V's, or the letter V's of big data that we've been thinking about and has been fairly well accepted. So one is veracity, V, right? So is it the truthfulness? Can we trust the data? So just seeing a boatload or a humongous load of data doesn't mean it's real. So you have to be very cautious about the provenance of the data, where you got it, who collected the data, whose data is it, and so essentially, can we trust the data? You should know something or a lot about that. The variety. So what are the different types of data sources that are in this big data set? Is it, for example, in financial sector, is it just transactions? Is it financial? Is it other types of data that go along with financial data, etc.? Velocity. So how quickly are the data being generated, transported, or accessed? Meaning, gosh, are they uploaded every minute, every second? Like, for example, in the financial world and stock market exchange, you'll see it, the ticker will be going every second or millisecond. Whereas in healthcare, it may be at the end of the day or at the end of a shift, etc. So velocity is the third V. Volume, how much data are there? Is there, is it as simple as gigabytes, which you all know of and are probably on your home laptop, and now you can put that much data on a flash drive? Versus are they higher numbers, petabyte and exabyte and all sorts of other names you'll see, which are huge, large data sets. And finally, I think this probably is the most important of the 5 V's. By the way, there are many other V's that people have added along the way, but I'll restrict to 5. The 5th one, which I consider very important, is value. So this, how much ever data you have, how fast can you get it, do you know anything about it, but does it provide value? So just having data for the sake of data is not useful, because it does take time and effort and resources to be able to harness and analyze these data. So the primary dictum in informatics, or Informatics 101, is what I've written down here. So data where you provide context becomes information, and then you provide further context, and that becomes knowledge. So data by itself is not useful unless you've converted to information, and then finally to knowledge that's actionable. So value for the data is extremely important. Now, let's jump straight into real-world healthcare data, which I'd like to share some thoughts about, and I'm sure you all know about this. The primary source of data for real-world healthcare data are clinical care encounters. So these are mostly from electronic health records, EHRs, which you all know when you go to your provider's office or to a hospital or emergency room or anywhere. Now, most of the outpatient and inpatient settings have electronic health records. So they're the provider's notes. They send a prescription electronically to your pharmacy, or they give you a prescription, or any other. And then, of course, diagnostic testing. So laboratory data, when you visit with your provider, they ask for a blood test or culture, microbiology, culture, etc. Radiology, so it'd be a simple X-ray all the way to CT scans and MRIs, etc. And there's also at the back end of the EHR data are things called administrative data. So as simple as admission, discharge, transfer, or ADT data. So it literally tells you when a patient was admitted, what time to a hospital or a facility, when they were discharged or transferred. So that really keeps an eye on how many patients and how full the facility is, etc. Along with clinical care encounters, there's a whole area of claims data. This is when, after the provider has finished seeing you, managing, and then finished at the end of the day or whenever they do the billing for this. This is where the entity or the provider's practice or the hospital's healthcare system sends a bill to your insurance company. That is actually a claim. So medical reimbursement for visits, hospitalizations, procedures. Those are generated fairly in real time. And by the end of the day, if your facility has submitted them, you can actually see those claims data at the payer level, of course. We may not see them immediately. And prescription data, like I said, your provider sent a prescription to your pharmacy, then the pharmacy has a record of those prescriptions. They're actually all cleared through a couple of clearinghouses. Now, very important part of this whole, the real world healthcare data is it really depends on what clinicians and providers enter into the EHR. So if they leave only one line note saying, Adi was here today, then it really doesn't help. And if they don't tell us what the visit was for, if there was no record of what they prescribed or what tests they ordered, then it's absolutely of no value to even to the healthcare provider and to the patient and for the next visit. So what clinicians enter richly into the electronic health record is really what we get out of it. And so that's very important. This is just a very high level schema of how data from the electronic health record are put into the electronic health record and how we take them out at the back end. So on the left here, you'll see in the in the boxes here, demographics, which is as simple as age, your address, your race, ethnicity, and any other details, your insurance details, etc. Diagnosis, visits, laboratory results, and e-prescriptions. These are structured data, which actually can be analyzed in a very nice way from a table, etc. And remember, these are your data every day. So whenever you've seen your provider, you've called a provider, you visited with the provider, you've gone to an emergency room, God forbid, but or admitted to a hospital or had a blood test, this is exactly how they generate data here. So it's your data every day. The unstructured data here, as I mentioned before, are not easily analyzable, and those are physician's notes. So you can imagine if the provider has written a nice long note saying, Adi came here today, he was not feeling well, he has a history of this, etc. Those are long notes that computers has difficulty reading. Humans can read it, but computers have difficulty reading it. Same thing with discharge notes. Radiology reports, like for example, an X-ray or CT scan report, and then pathology reports are also what they call unstructured data. And these are collated from different places, so hospitals, laboratories, different healthcare providers and settings. And at the back end, this is where your own healthcare system, where you seek care, does on a daily basis, is they aggregate these data. So they process them, make sure they're all good, reliable, complete to the best possible, and then they store them in data warehouses. Now, based on how the healthcare system is structured and how they do it, they actually mine those data for quality improvement, quality control, and for research, because that's how they understand what happened to a patient who had a heart attack or a hip replacement, or in our case, patient who has PI. And of course, there are data aggregators and vendors in the industry that collect these data, which are all de-identified and have no personally identifiable information or personal health information. And they make these large data sets available to anyone who wants to license them or purchase them, etc. And so we at government also are able to access these data sets. So in in essence, that's how the data that you generate by going to a provider are what lead to real-world healthcare data at the back end. Now, registry data, this is absolutely important, and for the PI community, USIDNet and all of you, IDF and you all are in the forefront of big data in terms of registry data here. Registry data have really some advantages over real-world healthcare data. You have more rich and hard-to-find details because somebody has taken an extra step to curate and say, this person had this condition, we verified it, had this treatment, and then they got better. Those kinds of details are a little bit more difficult to glean from just regular clinical encounters and real-world healthcare data. Now, that also means that registries are very resource intensive, right? It needs people, it needs resources, funding to be able to populate, have people check, recheck, call you, get those data if you've allowed your data to be in here, and then follow up on many different things. Now, for USIDNet, I would say, is big data. If you look at the screenshot, which I took just last week from the USIDNet landing page, I mean, gosh, there's data on 1,800 common variable immunodeficiency patients. No single institution will have that many patients at any given time. Over the years, of course, they would have seen that many. Same with more rare diseases like agammaglobulinemia, ataxia, and you can see the list here in terms of that. So DiGeorge syndrome, 564, that's big data for PI. Now, data on the PI patient journey, and I think you've already gotten a hint of this when I talked about clinical care encounters and real-world healthcare data. It's really going through where you present as a medically attended illness to a provider. It could be your local primary care provider. It could be to an outpatient clinic, emergency department, nurse, anywhere. And then a diagnosis occurs of primary immunodeficiency. And from my own experience and from all that you have taught me over the years, there's a delay even in that diagnosis of primary immunodeficiency. But luckily, once that is done, there's very good management now. Over the past few years, even more, I think, improvements have been made, and all those are recorded. So be it a lot of investigations, CT scans, MRIs, etc., and then either medications or immunoglobulin replacement therapy, which is common for our CVID patients, etc. So those management records are all very important. And then finally, hopefully, many of you have gotten better and been able to continue on with your life. So your quality of life has improved, your health outcomes decreased, hospitalizations, longer lifespan, infection-free, etc. So this is really the patient journey that happens, and there's data from each of these stages in the real-world healthcare data. Now, and those are the ones that have been mined and analyzed heavily over the past several years. So the first is diagnosis of PI, and we all know that there's, identifying patients with PI, and all of you have lived through this either for yourself or your family members, where people are not able to give that diagnosis immediately. There's several older studies saying there's 4 to 7 year gap between first symptom and a diagnosis. So now, fortunately, there's accumulating literature, published literature in the medical literature on studies attempting to identify patients who may have PI. Many publications, including those with symptoms, presentations, and features that could be used in big data mining. And I've pointed out 2 recent ones, and the references are at the back at the end of the slide set here. And also just to mention that these 2 papers and all the others that I've cited today are in the public domain, so you can actually access them free of cost through the internet. The first one is the early diagnosis of primary immune deficiency on your left disease using clinical data and machine learning. So really, machine learning, simply put, is a way to teach a computer to find a primary immune deficiency patient. So you actually have to make them learn. So you have to show the machine, in this case a computer, saying this is what a PI patient looks like. this is not what a PI patient looks like. And so the better data you have to show what a PI patient looks like, then you let the machine loose and it goes on big data and say, so having looked at a real good example, these set of patients may be PI patients, etc. So that's what it's doing. The summary is right there, prediction model for early diagnosis of PIDD using historical data that are related to symptomatic care, which has potential to fill an important need in reducing the time to diagnose PIDD. So that's very important and really good studies coming out there. Now, just a few years ago also, there was a group here, Dr. Orange's group here, Jordan Orange, about calculating primary immune risk vital sign via population-wide analysis of claims data. So again, they were trying to stratify folks and say, if this person had a higher score, then maybe they look like, or they may be a primary immune deficiency patient. So they took a large data set, and then population-wide informatics approaches can facilitate disease detection and improve outcomes. So early identification, this is an important point they raise here, saying early identification of the 98 patients in their study with confirmed or suspected PI described here could represent an annual cost savings of up to $7.7 million. I mean, that's the monetary value, but also imagine the per person value in terms of quality of life in earlier diagnosis, antibiotics, prevention, treatment, replacement therapy, etc. Now, one thought I had in reviewing some of the literature, and by no means is that review exhaustive because people are adding studies all the time. I was thinking, studying pediatric and adult populations separately. So I hadn't seen that specifically called out, though many of these studies showed all the way from pediatrics to adults, as you know, and I'm an internist and adult physician. So there's a certain, difference in how adult patients would present with CVID versus pediatrics. So that's one consideration for our community. The other one is evolving early diagnosis features and presentations from the literature and from clinical studies, etc. Even at the time when I was practicing actively at the University of Utah, which was several years ago, I would see patients referred from GI clinic, the gastrointestinal clinic, and the pulmonary clinic. Hey, wait a minute, this person's either their presentation, their symptoms, then their imaging studies or pathology showed something that we don't see, and gosh, could they actually represent a PI patient, and so then we do the studies and then confirm or rule out, etc. So those features are evolving, I think, every year in terms of what we learn more and where do our patients present. And healthcare utilization prior to the diagnosis. So for example, many of my patients in the adult practice for immune deficiency clinic were referred from ENT. So this is a patient who had seen the ENT doctor, 5 times in the past 3 months, which is unusual. And so are not resolving their sinusitis with usual antibiotics or having repeated or a long history of that. So I've had really good discussions with ENT surgeons to be able to rule out then PI, and we found several of those patients who then we put on replacement therapy, and fortunately their sinusitis. So I've not seen specifically healthcare utilization used as a feature in machine learning and these algorithms, etc. So maybe that's something we could look at specifically for the adult patients. And as I've mentioned just a minute ago, specific manifestations such as autoimmune and inflammatory conditions. So looking at gastrointestinal rheumatology, pulmonary, and what we had done at the University of Utah, and I'm sure it's repeated in many, many, many places around the country, is talk to our colleagues and say, hey, and we used to give annual lectures to fellows in each of these specialties. Say, hey, if you see a patient, they're thinking about it, there's no need to do this extensive workup, but maybe there's 1 or 2 screening tests that you can do and then call us for help and consultation. Now, the opportunities when you use real-world healthcare data is strength in numbers. As we'd mentioned, PI patients, fortunately, are small in number at each healthcare system. So learning from those small numbers is difficult if you limit to only one. So aggregating across a region or the country is really important. And of course, challenges are there. Real-world healthcare data are not perfect by any means. And if a patient has received healthcare in different systems, then they may not be identified as the same individual, or you may not know what happened to them and they may not be in your data set. And those two papers I mentioned and several others, there's really no algorithm that'll be perfect, right? There'll be false positives, meaning the algorithm or the computer will call somebody a possible PI patient when they're not, or false negative is that they will miss someone who was a PI patient. So there's no perfect algorithm. We will never probably get to 100% performance on any of them. So you have to take it for what it is and maybe do serial algorithms to, take the universe of 1 million patients, narrow it down to maybe 50,000, and then another algorithm to narrow it down to 5,000, and then do some screening tests, etc. So that's my sort of practical view on it. So that was the diagnosis. Then management and health outcomes, an important area of study because we don't have clinical trials for every single intervention that we do or can do for our PI patients. And so in that respect, USIDNet is a shining star. Again, strength in numbers and the rich data set that can be had from a registry. And just as of last week, the website lists 78 publications, which is huge in an area such as PI, which is difficult to gather up patients and study them. So just examples of 3 very recent ones which caught my eye and I thought were very important. Outcomes among racial and ethnic minority groups with X-linked agammaglobulinemia from the USIDNet registry. See the importance of talking about a rare disease, X-linked agammaglobulinemia, then looking at racial ethnic minority groups. So looking at small numbers to trying to combine them with registry. And this one was also very important. I've had 1 or 2 CGD, chronic granulomatous disease patients in my career, and very challenging to manage and frustrating for both provider and the patient. And here they're talking about CGD with inflammatory bowel disease, the presentation, treatment, and outcome. So you saw the full spectrum of the PI patient journey here. And I thought this was a nice one from a few years ago. Risk factors for pneumonia and primary antibody deficiency patients receiving immunoglobulin therapy. So even on therapy, some patients do have pneumonia. So data from USIDNet, etc. And those are also available. I have the references at the end, and those are also freely accessible. Under management and health outcomes, as you all know, in the past several years, COVID-19 has really wreaked havoc on our PI community. So we've talked about vaccinations, we've talked risk due to COVID-19 and outcomes. And so we're very fortunate. There is a group here at CDC who's also interested in primary immune deficiency and outcomes. And so I was just privileged to be part of that group, and we published recently this article. It's severity outcomes among adult patients with PI and COVID-19 seen in emergency departments through a year and a few months in April 2020 to August 2021. So what we did was CDC has access and licensed a database called Premier Healthcare Database, where they collate data from 873 US hospitals that have emergency departments and inpatient data there. And we looked over that 1 year and a few months period, April 2020 to August 2021. So we were able to look at 1.2 million patients that were seen in the ED. And from the ED, about half of them were actually admitted to the inpatient setting. So seen in the emergency department, then admitted. And in this large database, we were able to find, based only on ICD coding, 853 COVID-19 patients with PI. So they had to have had COVID diagnosis and PI diagnosis. And we used a broad net to look at it. And as you can imagine, the most common was still CVID and humoral immune deficiency. So there's really no single center or healthcare system where you'll find 800 COVID-19 patients with PI seen in the ED. So we looked at that, and the punchline there was that the risk was higher in PI patients for three things: hospitalization, ICU admission, and also invasive mechanical ventilation, meaning being put on a breathing machine. So we were able to show that comparing COVID patients with PI, COVID patients without PI, etc. And so you might say, well, we already knew this. This is intuitive. Our provider said it, we've seen it, etc. But this provides real-world evidence. I mean, intuition is one. Our clinical experience counts for a lot. I'm not discounting any of that. But actually putting that together as real-world evidence is very important for an agency such as ours, where we can then put PI on the risk factors for adverse COVID-19. So you can imagine like diabetes and lung disease, etc. PI, intuitively it is, but now we have evidence to say PI patients also have adverse outcomes. It's important to close that loop in one way. And so again, here, management, there's need for real-world evidence on many questions. Even when I was at the University of Utah a few years ago, we were talking about management of ILD, or granulomatous lymphocytic interstitial lung disease in CVID patients. I was privileged to care for several who had this condition, and there was no one particular treatment or management that was studied or worked. So, and not every intervention, like I said before, can be studied with clinical trials. So, example, looking at GL-ILD patients and looking at what happens to them, what sort of treatments they've received, was it rituximab, was it not, and then following them along are very important. Longitudinal data on incidence of cancers in recent times with either diagnosis and prompt, with earlier diagnosis and prompt treatment. So we've all studied this in medical school, and my mentor, Dr. Harry Hill, had taught me so well early on, now 15, 20 years ago when I started working there, that CVID patients have higher incidence of cancer. So you have to have them screened by their primary care provider for age and sex, gender-appropriate screening. But with earlier diagnosis and prompt treatment, in our practice over the years, Dr. Hill had said, well, we've seen only one or two cancers. So now, more recently, we'd like to know, are the incidence of cancers better, worse, or are they different than they were even 15, 20 years ago? And then this has been something, a pet peeve of mine. We study it in papers and in the textbooks, and says CVID patients get uniquely enteroviral, which is an enterovirus that usually occurs in the fall, common among kids, etc., but that causes encephalitis. But in the 15, 18 years, I've never seen that, and I don't think Dr. Hill has either. So question is, it's in the textbook, it was written from a paper 20, 30 years ago, maybe longer. Now, is it really seen in CVID patients? So I'd love to be able to answer the question, are you able to pick up enteroviral encephalitis across the country? And of course, rarer conditions among our PI population, and then outcomes, which are very difficult to study. So summary, and hopefully we'll start the QA in a minute. I would say, and again, thank you for this amazing opportunity to visit with you all. Big data are here to stay in the medical clinical world. There is a place and role for them. They're complementary to clinical trials and observational studies. So you can't say, oh, you have to stop the randomized trials, you have to stop the observational studies. I think these are a good adjunct to it. So they have a definite role in generating evidence for the diagnosis and care of PI patients, even more important than other conditions because of the rarity of our diagnoses and trying to gather data on large numbers of patients. Registries offer rich data, but as you all know, and IDF knows, and USID-Net people know, it's very, very difficult to maintain and sustain a registry in terms of resource intensiveness. It's a good thing to do and requires sustained funding resources and interest. And then now I would say there's excellent examples of using big data across the PI patient journey. So newer technologies are being applied. You've seen the word machine learning. You've now heard artificial intelligence. Certain our groups and our clinicians and researchers are using AI methods. Machine learning is one of them, and I'm sure there's more to come. But in all of this, you must remember that you are all the real stars. I mean, it's you who've gone to a healthcare provider, you've allowed your data to be put into an EHR and then used for quality control, quality improvement, and for studies here. So thank you for allowing us to study your data, and I'm hoping that this actually helps the care management and earlier diagnosis of PI patients. So these are the references. All are open or public access, so just to mention. And I'll stop here with a great big thank you to the organizers and to all of you for listening here. I'll stop here. Over.
Thank you so much, Dr. Gunlapalli, for providing the overview. We now have time, and we've got quite a few questions to go through. But before we begin, please remember that everyone's treatment and conditions are unique. The information presented during the session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with questions concerning a medical condition. So, with that being said, we have some great questions. I'm going to take myself off camera. You're the star at the moment, Dr. Gunlapalli. So hold on. I'm going to take myself off camera and read these. All right. So the first question we have is, and this you alluded to this a little bit in your discussion, is there data on how those with PI are differently affected by COVID? Does it take longer to leave our bodies? And of course, that's a general overall question. Diagnosis by diagnosis may be different, but based on the publication you were part of, briefly, what did you find?
Yeah, unfortunately, from the database that we studied, we couldn't tell whether the PI patients had a longer duration of COVID. But I will say from other studies and other immunocompromising conditions, not PI specifically, but secondary immune deficiencies such as cancer, bone marrow transplant patients in general, it is quite well known that those patients will harbor COVID-19 virus, SARS-CoV-2, the virus, for longer. And there's some famous examples of shedding, which they've been able to pick up in studies for weeks and months, etc., and all that. So I don't recall, and clearly, please don't quote me on this, my review of the PI literature could be outdated even by a few months now. I have not seen specifically in PI patients, or maybe there was one or two. But I would say in general, patients with immunocompromising conditions can harbor and shed virus for longer. Thank you.
Great, thank you for that. Our next question is, historically speaking, in your opinion, what have been the top 2 successes and worst 2 failures of medical big data management? And what lessons might we learn to help with primary immunodeficiency disease management?
Boy, that's a very good question, and thank you for really making. I would say maybe the top 2 successes are a little bit easier. I think what I've seen, and Chris, you and I were on a call with several researchers who are working with the PI community. I think trying to get to that earlier diagnosis, and even if we're able to, narrow down the population from 1 million to 50,000, and then 50,000 to 5,000, to say, hey, let's screen some of them or a portion of them for PI, I think would be a real huge success. Now, that will take some more time, I think, and then be able to show that, yes, we were able to identify them and then manage them, et cetera, will take time. So that's probably one. The other success of big data, I will take from the literature, which is not from the PI. So there was a article in JAMA, which is the Journal of American Medical Association, about 4 or 5 years ago now, gosh. I mean, COVID really messes with the time frame for me. I'm sure it's for all of you, but what they did was they actually had a computer using machine learning and some type of artificial intelligence look for retinal diseases using the retinal pictures, photos by training them. So it was for diabetic retinopathy. So trying to pick up earlier signs of that and then helping clinicians try to figure out who has early diabetic retinopathy, and then maybe you can get them quicker because that saves lives. So I think that even when I looked at this, I'd given a talk during the COVID pandemic about AI and the other stuff, and at that time itself, it was very highly cited. I'm sure now it's even more highly cited. So success is where I think, in my opinion, completely separate from anything the government or any other entity is saying, is that when we use machine learning, artificial intelligence, big data to help the provider manage the patients in front of us better, I think that's a success here. So computers will never, I think, replace us completely. But if they can help us think of something which we hadn't thought of and just prompt us to make sure that we do the things that we're supposed to do on the checklist, I think that's a success. Now, the pitfalls, there are definitely pitfalls because two I'll mention, and this is from my own experience in reading the literature. I've not been directly in the field, so I don't have personal knowledge. So one is where we have some knowledge of is when you train the computer, like we talked about that, right? You have to train the computer and say, this is what a PI patient looks like. This is not a PI patient. You have to, the population which you use to train may be different from the real world population because you have to find so many PI patients, right? So you have to, what they call oversample and selectively find those patients. But in the real world, it's still very rare. So, and we did that in the VA for other conditions. So when you train on a certain data set and then you let the algorithm loose on the real world data, it performs differently. So that is a pitfall you have to be careful about. Nowadays, of course, they talk about if you train the algorithm on certain data set with certain racial ethnic characteristics, then it'll behave poorly, or it'll perform poorly when you look at the real world and where there's different race ethnicities. The other one is really being able to trust the data and verify the data. So there was a famous example. I don't have the reference right in front of me, but there was during the COVID time, there was an international database that people used and then made a statement about something. I think it was a treatment or so. But soon after, people started wondering where the data came from. And gosh, unfortunately, the authors had to retract the paper just, I think, a few months or a few weeks afterwards because they found that the data were not reliable. So that is the pitfall. So I think going back to the 5 V's, the veracity V of the data, and then truly value that. I know it was a little bit longer answer, but the question was just amazingly well put. Thank you. Over.
It was, and I'm going to add my own failure from my perspective to this. So I think one of the issues we have is that, at least in this nation, our data is very disparate. It's over many different institutions. We don't have a centralized healthcare system or a centralized single electronic medical record, which gets to actually some of the other questions here. So there's a question in the chat, and I think it ties into this. Asking about, for example, Wiskott-Aldrich syndrome, and apparently this question stating that the largest one is in Germany with 700 patients with Wiskott-Aldrich contributing data, which is amazing. But the question is, what methods might be used in order to be able to increase the data? So, and I won't answer this for you, but as an example of the last question and a failure, wouldn't it be great if we could not just in the US share this data among all these, break these silos down, but internationally find ways of joining these things. So a lot of these more rare, or rare of the rare, as we like to say, we get, more folks in there. So I think those tie together, but I'll let you expand on that if you'd like before we go to the next question.
Absolutely. I think, I knew about the Wiskott-Aldrich, the rarity of that, of course, and and databases in Europe, but this is really nice to hear about that and can study it. The answer is ideally yes. The opportunities are there. However, the significant challenges, right, in terms of, I mean, even within our own country, in terms of data use agreements, the HIPAA, restricted data sets so that there's no personally identifiable information or personal health information, etc., those kinds of things. So imagine then trying to put a data use agreement with someone from Europe or that. It can be done, and it has been done, I think, for international. So a good, honest broker, a third-party entity can be done. In all of this, even in the US, we face the challenge of interoperability, right? So if you take a data set from health system A, and they put the name in this way, and the age in this way, and the sex is coded at birth, sex at birth is coded this way, and the date of birth is put this way, then you want to make sure that it's exactly the same way or can be quickly mapped to system B, and then it goes all the way to system AAA and hundreds of systems. So imagine then simple things like in Europe where they flip the date from the day and month to month and day, etc. Right? So imagine those kinds of things and famous examples of not being compatible in terms of kgs versus pounds, etc. So I think it can be overcome if you have a good data model and you can what they call semantically map and say, yes, this field should be this field, so you can actually combine them. It takes time and effort and a huge upfront investment on that. So I would say the answer is, gosh, I hope it can be done, but it'll take a lot of interest, commitment, and then, of course, resources to do it right. And maybe for the rare diseases, that is the right example. Over. Thank you.
Great. So I think we have time here for just about one last question. So, and it looks like a few folks have been interested in this. How do we correct mistakes on EHRs, previous misdiagnoses, medications, allergies, when a primary care provider either won't, is not able to, or is not affiliated with all the different places, all this disparate information has occurred? And now I understand it's probably going to vary EMR and institution, but generally, what type of advice can you give to the people who are curious about this?
Yeah, no, that's an important point. I'm truly not an expert in that loop where where patients actually truly should and now have access to their own records, right? And so even when I was at the University of Utah and the VA, they were making the notes also accessible to the patients, which is perfectly right. I truly don't have a good sense of that. I would please maybe start with the medical records department or the provider and say there's this really major mistake, and so maybe they have protocols at your healthcare institution, at the provider's office, say this is how in writing you have to do it. So I apologize. I'm not an expert in that area, and so not having been in that field for now a few years and out of the clinical world, I unfortunately I'm not able to give you more specific advice. Over.
So I can say from my own personal experience, I found that in my own EMR, and at least through my version of Epic, which happens to be the University of Maryland Medical System, I can actually go in and sit there and note this is not correct within the app or with the EMR itself, either from my phone or otherwise. It's reviewed, of course, but a good thing is, I think, to have a conversation with whomever your healthcare provider is where they found that, and they should be able to get you an answer. So with that being said, I think we're going to close this out with just a few moments left. So our time together has come to an end. So thank you very much, Dr. Gangapalli. It's been an honor to have you join us today. Remember, everyone, this session is just one of 39 unique learning opportunities provided through our 2023 PI conference. We hope you'll continue tuning in today and tomorrow as we explore other critical topics for the PI community. All right, everyone, have a great rest of the day and evening. Thank you so much for joining us, and we'll talk to everyone soon.
Thank you again for the opportunity. Bye.
Thank you. Bye, everyone.